Hello everyone, welcome to our second module. In this module, we'll be discussing the important topic of seeking healthcare. Hopefully you're seeing a pattern in these lectures already. Topics that seem very straightforward on the surface are actually quite complicated and interactive when examined more closely. The same is true for our interactions as humans with the healthcare system. The first thing I'd like to talk about is seeking medical attention, as this is typically the primary thing we think about when considering healthcare. Most of the time, our medical system is focused on treatment or tertiary prevention, where we're not treating a particular disease until the symptoms are already present and fully established. This model of care is in opposition to primary prevention or secondary prevention, where we either try to prevent a disease from developing in the first place or to try to catch an illness in its very, very early stages so that we can treat it more effectively and prevent it from becoming full-blown. While there are some pushes to advance primary and secondary prevention, because it's more cost-effective and helps prevent suffering on the individual level, our current healthcare culture tends to focus around cases where individuals are already experiencing symptoms and seeking medical attention for illness. It's important to note that people often aren't seeking treatment for disease alone, which is different from illness. Disease is the actual physical process occurring within the body that's resulting in some sort of observable physical damage or dysfunction. And disease states or processes can certainly exist even if those have not been recognized or diagnosed yet, because it has not yet manifested into symptoms that a patient would complain about or seek treatment for. Of course, this happens all the time. People can have high cholesterol or high blood pressure or high blood sugar without yet knowing it, especially in the early stages, because they don't have symptoms they can recognize, or because the symptoms are being incorrectly interpreted or attributed to something else. For example, you might attribute fatigue to stress at work instead of a cardiac condition. Illness, in contrast, is the experience of being sick and having been diagnosed as being sick. So to be ill, one has to have a disease process, but also has to have been recognized and diagnosed as being sick. In our society and healthcare culture, doctors are definitely the gatekeepers for medical care because individuals aren't considered to be officially ill until they've received a diagnosis, which we obviously can't make on our own, though we often try by accessing sites like WebMD. So the diagnosis that the expert healthcare professionals provide is sort of like the sanction for an individual to receive further medical care. However, even doctors have to sometimes justify the type or the course or the intensity of the medical treatment decisions that are made to individuals within the health insurance or managed healthcare organization. And oftentimes they're justifying or arguing decisions with individuals who have significantly less education than they do. So the doctors, via the diagnoses, are the gatekeepers for medical care. But there's also been a shift for the administrators of the managed healthcare organizations or health insurance organizations to be gatekeepers for medical care as well. Sometimes this can lead to very frustrating experiences for the patients and medical providers alike. I think that in the great many cases, individuals who have a health issue go to the doctor, they're correctly diagnosed, they receive appropriate care, and their symptoms are treated or disease is cured if that's possible. And we can all in all say that the treatment experience is a successful one. However, there are also a great number of cases where the process does not go smoothly, or difficult decisions have to be made. Here's a link to some recent coverage about a cure for hepatitis C and the difficult decisions around determining who should receive this treatment given its extremely high cost. For an individual to seek out medical attention, They must be aware of either changes in their functioning or the development of new physical sensations or experiences that the individual recognizes as troublesome, distressing, impairing, or potentially indicative of a particular condition that needs attention. This requires them to have an illness representation, or a belief that a group of specific symptoms are often experienced together and represent a specific illness that matches the symptoms he or she is having. Illness representations also include beliefs about the cause, timeline, or prognosis, and consequences of the illness. Of course, sometimes illness representations are inaccurate, and sometimes individuals match up their own symptoms to an illness representation in a faulty manner. Beliefs about the causes of a specific illness are another aspect of the illness representation that can have importance in terms of seeking health care and also health behaviors. An individual who has an inaccurate illness representation may not recognize that he or she has an illness and thus fail to seek treatment. Or an individual who feels that health change will not lead to any significant change in the prognosis for or consequences of the illness may not be likely to follow their doctor's advice. I want to underscore the fact that illness representations, or our beliefs about particular illnesses, influence our physical, emotional, and social behaviors and outcomes, whether they are true or not, whether they are accurate or inaccurate. In addition to the impact of illness representations, individuals really differ in how they recognize or interpret physical sensations or symptoms. For example, people tend to have very characteristic ways of monitoring their bodily symptoms and well-being. Some people have a very strong internal focus and are more likely to detect symptoms than individuals who have a strong external focus. Sensitizers are individuals who cope with health problems and other aversive events by closely scanning or monitoring their bodies and environments for information. These individuals tend to be more neurotic and prone to stress and tend to have a relatively low threshold for seeking health care. In contrast, repressors are individuals who cope with health problems by ignoring symptoms or distancing themselves from potentially stressful information. They are more likely to avoid medical evaluation and care. While neither tendency is inherently better or worse than the other, as each has its pros and cons, understanding if someone is a sensitizer or repressor helps us understand things about their interactions with the healthcare system and plan for care appropriately. For example, if my husband feels bad enough to go to the doctor, I really know it's a serious issue and must be addressed as quickly as possible. In addition, the amount of stress that one is experiencing seems to play a role in how likely individuals are to seek out health care, with those who are under more stress seeking out more health care. One of the ironic and troubling aspects of this, though, is that patients who are perceived to be under greater levels of stress by medical professionals are seen as being less likely to actually have a disease of any kind of medical condition that needs attention. The individuals with high stress go to the doctor more, but are perceived to have less actual medical needs. When a healthcare professional perceives the situation in this manner, a patient may receive less diagnostic tests, may receive a shorter period of discussion that could have illuminated an actual disease process, or less likely to receive treatment options. As we'll learn in a future module, being under more stress actually makes you more likely to be having true physical conditions. Thus, providers need to be aware of what type of patient they're interacting with, but also aware of their own assumptions and the ways in which these may actually hurt care. In addition to individual differences, there are some group-based differences that seem to impact upon awareness of illness and decisions regarding seeking care. Older individuals utilize the healthcare system to a much greater extent than younger individuals, probably because older individuals actually experience more often, though it is a misconception that health significantly and permanently declines due to advancing age, as most older adults remain very healthy. In addition, older adults are encouraged to engage in more preventative and routine care and are more pessimistic, but possibly more accurate, in their sense of how at risk they are for illness. Adolescents, in contrast to older adults, often have an optimistic bias about their health, where they see themselves as being less at risk for various health problems than they actually are. Older adults also have less time constraints and time-driven responsibilities, like employment, childcare, and family responsibilities, that would make just scheduling an appointment challenging. These sorts of responsibilities tend to make young and middle-aged adults delay seeking health care until the problem at hand seems more serious. In addition, older adults tend to have more recognition of their own mortality, which can cause anxiety, which may promote more frequent interactions with the healthcare system as well. So age obviously plays a role in seeking health care. Gender also plays a role in how individuals interpret physical symptoms and interact with the healthcare system. For example, women are more likely than men to report physical symptoms and to utilize health services. Some have proposed this may be related to becoming more comfortable with such interactions through gynecological and/or maternity care, or through interactions with pediatricians if one is a mother. Another thought is that women are actually more susceptible to illness than men because of the stress of and risk of exposure to antigens when taking on more caregiving responsibilities than men do. Some data also suggest that women may be more sensitive to their internal bodily experience than are men, and that this may play a role where, in the presence of the exact same physical symptom, the increased awareness promotes seeking healthcare attention. It's also possible that women seek more healthcare than men simply because female healthcare is more fragmented, requiring visits with a primary care provider and also with various specialists for reproductive health and various screenings such as cancer screening or bone density tests. Finally, it's also possible that men actively avoid seeking health care. Data does suggest that men are more likely to avoid seeing a doctor, even when faced with potentially serious problems. Some interesting data that bear on this. Over 1/3 of men said that they would not go to the doctor immediately, even if they were experiencing chest pains or shortness of breath. And this is very concerning because these symptoms may be indicative of a heart attack, which needs to be dealt with by medical professionals in a very short span of time. Of course, the way we are socialized by gender may play a role as well. Sociocultural factors also seem to play a role in individuals seeking out medical care. For example, we know that individuals of high socioeconomic status generally report fewer physical symptoms and better health than do individuals of low socioeconomic status. When they're sick, individuals with high socioeconomic status are more likely to seek out health care than are individuals of low SES. And this is often because individuals of low SES wait longer before seeking treatment, likely due to the higher relative cost of healthcare for these individuals. In that, a $30 copay means something very different if your income is $75,000 versus $15,000 per year, or due to having a health insurance plan of lower quality and higher deductible, where perhaps you have to pay up to $5,000 or more each year out of pocket before the health insurance would even kick in, period. So individuals of low socioeconomic status are more likely to delay seeking medical care, until they're sure it's a true disease, but this often means illness becomes more severe before treatment can be administered. Individuals of lower income are also engaging in less preventative behavior and also less healthful behaviors at all, overall, and thus are more likely to develop particular diseases. Of course, the reasons for this are not always straightforward or due to voluntary choice. For example, individuals with less financial resources may have difficulty accessing healthy food. Research suggests that food deserts exist, for example, where the availability of healthy food is almost non-existent. Of course, healthy food also costs significantly more. The markup on something like spinach is huge compared to something like beef. Perhaps the health-related education received by individuals in lower quality schools is also of a lower quality, so there are a number of factors to consider. There are also specific subcultures, even within the United States, that have their own specific beliefs that impact upon seeking health care. For example, there are particular religions that believe that illness is a representation of God's will and feel that disease should be dealt with only through prayer and not through any type of medication or other type of medical intervention. There are also groups who hold strong beliefs about personal choice and the potential negative consequences of medical interventions. This is a really difficult and contentious issue. For example, if someone turns down medical treatment while having an allergic reaction, is that suicide? If a parent refuses to get their child vaccinated and they die from the illness the child would have been protected against, is this medical neglect? I've linked a recent article about an outbreak of the measles in the United States and how this relates to a particular subculture. Interestingly, even situational factors can impact upon how people interpret their physical sensations. For example, in the 1996 Olympics, gymnast Carrie Strug badly injured her ankle, but still managed to land a vault on her feet in order to ensure gold. We can push through pain or discomfort when something important is on the line. And often people report they actually are not as aware of the pain or discomfort until afterward. Thus, the perception of the physical symptoms actually changes. In contrast, individuals who are undergoing evaluation for disability status are facing the potential for a great deal of secondary gains related to any type of disease that may be present, such as the possibility of a lifetime of guaranteed income based on the presence of a particular illness or disease. And it's very likely that these individuals may be paying a great deal of attention to their physical symptoms and may be interpreting them as more debilitating or as causing more impairment because of this context. This is not to say that this is intentional misrepresentation, but rather that the context in which we experience illness can have a profound impact on how we interpret what we sense. As another example of this, some data suggests we tend to exaggerate symptoms that we expect and ignore symptoms that we don't expect. I'm going to use a really sort of overused example to illustrate this, so bear with me. But let's say for females who experience characteristic premenstrual symptoms, perhaps bloating, fatigue, maybe even irritability or other psychological symptoms, if they continue to have these on a monthly basis and they've grown to expect them, the reaction to those expected symptoms might actually be greater than the reactions would be to the same symptoms in a woman who doesn't tend to have these symptoms every month. The situation we are in and our expectations related to this situation play a role in how we're reacting to physical experiences. Again, the tendency to be influenced by situational factors or even our own expectations when interpreting symptoms is not something unique to patients. In fact, it seems to be a significant risk factor for healthcare providers as well. There appears to be a tendency for medical professionals to attribute newly reported symptoms to a condition that has already been diagnosed, rather than to potentially undiagnosed comorbid or coexisting conditions. As many as 1/3 of all patients who are hospitalized for a physical condition may suffer from a psychological disorder as well, which may or may not be diagnosed. In a case where a patient is hospitalized due to obstructive lung disease, for example, fatigue and a lack of enjoyment may be attributed to the lung disease rather than considering a separate problem of depression, even though fatigue and lack of enjoyment are characteristic symptoms of depression. An opportunity to offer treatment for depression, then, via therapy or medication, can easily be missed. Of course, as I've already referenced in this module, there are many times that individuals do not seek out medical care when it really is needed. It really is true that seeking timely medical care when symptoms arise can mean the difference between life and death. For many diseases, early detection can have a huge impact on what the ultimate outcome or consequences of that disease are going to be. Opportunities for early detection can be missed because of a faulty illness representation, because symptoms are ignored or misattributed, because symptoms are minimized, because care is put off due to pragmatic reasons like scheduling or cost, because the provider cannot provide care in a reasonable time frame, etc. On the flip side, there are also individuals who will overutilize health services, sometimes even to the point of being diagnosed with a mental disorder, and often to the significant frustration of the medical provider. In either case, the probability for effective care is reduced. To be clear, the reason that illness representations and the individual and group factors that influence seeking health care and the way one interacts with the healthcare system are important is that knowing the individual and contextual factors involved can help ensure effective care is delivered. For example, the way a provider interacts with a sensitizer versus a repressor should be somewhat different to achieve ideal outcomes. Understanding if someone has had to delay care because of lack of motivation versus lack of recognition versus psychosocial barriers such as limited income has very important implications in terms of how the care plan should be addressed, even if the specific medical treatment advice is identical. There's no question that there's a hard science to medicine, such as how bacteria duplicate and how cancer spreads through the body. However, there's also an art form to medicine, and much of the art is knowing how to understand the contextual factors that influence a patient's behavior and being able to communicate effectively about these things as well. So how can a health psychologist help promote effective healthcare interactions and outcomes? Certainly one thing that health psychologists or other mental health professionals can do is recognize individual differences that may impact upon how individuals react to physical symptoms. For example, health psychologists can help recognize whether a patient is a sensitizer or a repressor and help the patient modify the beliefs and behaviors that go along with this to promote more effective healthcare interactions. Health psychologists and other mental health professionals can also recognize when individual patients have faulty illness representations and can help correct these through psychoeducation and then help develop a behavior change plan. For example, focusing on how weight loss can impact upon diabetes management and helping the patient develop strategies for losing weight. Mental health professionals working in the medical field can also help medical providers become aware of psychosocial barriers, such as transportation difficulties or caregiving demands that seem to be interfering with medical compliance, or help accurately identify if there are any mental health conditions that are comorbid with, or perhaps have actually been misdiagnosed as, a medical problem. And of course, health psychologists can help individuals cope with medically related distress, such as the worry they may face when awaiting the results of a biopsy or when undergoing chemotherapy. As a whole, mental health professionals can be knowledge about the individual differences and the situational factors that bear on seeking medical care, and can help intervene at the systematic level, at the health professional level, and at the patient level to try to promote more accurate knowledge, more adaptive behaviors, and decrease distress and suffering. Another area where mental health professionals may be able to offer some beneficial guidance is in the case of patients who are hospitalized and struggling to adjust to these new circumstances. Hospitalization can come with some definite risks on the biological side, such as exposure to antibiotic-resistant infections, as well as some recognized risks on the psychological side as well. Hospitals operate on a system that requires a great deal of efficiency, but does not focus much on the global well-being of the patient. Instead, hospitals tend to be a total institution that takes control of virtually every aspect of the patient's life. The patients are expected to conform to established rules for eating, sleeping, and receiving visitors, and they're expected to make their bodies available for examination and treatment at any time of day or night with no notice. My grandmother suffered a severe heart attack recently and was hospitalized for a little over a week. I think she really struggled with feeling she lost control of her own decisions and daily activities, which can be very upsetting. While the way individuals cope with and adjust to hospitalization often mirrors the way that they cope with and adjust to other big stressors in their lives, we know that hospitalization is a special case of interaction with the healthcare system that presents a unique set of conditions and needs on the part of the patient. Psychologists can play a role in promoting the well-being of hospitalized patients by consulting with healthcare providers and intervening directly with patients and their families. Given the depersonalization and the loss of control that tends to accompany hospitalization, mental health professionals can educate healthcare professionals on the importance of good bedside manner and can stress that hospital employees, be it administrators, staff members, or actual direct care staff, need to focus on overall patient well-being. Mental health professionals can advocate against making hospital decisions based strictly on economics. They can also sort of fill in for good rapport from the medical doctor. A psychologist or other mental health professional might work in conjunction with a doctor who is known to have poor or cold bedside manner and can allow the patients the opportunity to process their reactions and concerns regarding a diagnosis or treatment plan, while allowing the patient to feel respected and validated. Whether we're considering inpatient or outpatient treatment, doctors are not chosen for medical school on the basis of their social skills. Traditionally, medical schools have placed very little emphasis on social skill training or bedside manner. We also know that medical providers vary in their attitudes about what their role and what patients' roles should be. Some providers view themselves as the expert and believe that patients are almost like children who should be expected to passively comply with everything that they say. We also know that some healthcare providers have negative perceptions or have negative stereotypes of certain types of patients, and that they are often unprepared to communicate about really sensitive health matters. Overall, multiple factors are combining to make patients be relatively unsatisfied with the care that they're receiving, and bedside manner appears to be a piece of the puzzle. Luckily, medical and nursing education has recently begun to focus on communication skills training as a fundamental component of medical education. As the education and norms surrounding medical attention and practice continue to develop, psychologists or other mental health professionals can work with healthcare providers to educate them about these issues, train them to have better communication and rapport building skills, and fill in for poor bedside manner in the case of the care of specific patients. Getting back to the notion of hospitalization, obviously psychologists or mental health professionals can also provide direct intervention to help patients cope with hospitalization. One thing they can do is provide good psychoeducation so that patients have accurate expectations about what to expect during hospitalization. This promotes informational control through a focus on the procedures and sensations that accompany a particular diagnostic test or treatment or period of hospitalization. We know that individuals who have realistic information, which tends to be associated with moderate anxiety, tend to have the best outcomes. We also know that sensitizers in particular are going to welcome as much information as possible, although we have to be careful to ensure that accurate attributions don't increase monitoring behaviors to an unhealthy extent, especially in those sensitizers. We must also make sure that it doesn't induce a greater amount of stress than normal if information is sort of forced upon people who prefer to cope through repression. Another way that psychologists or mental health professionals can directly intervene with patients is through a focus on challenging thoughts about the hospitalization or the inherent diagnostic tests and treatment, or through promoting more effective use of coping skills, either addressing interpretation or addressing related behaviors. This can promote either cognitive control or behavioral control. Cognitive control directs patients' attention to the positive aspects of the procedure. For example, the procedure will ultimately result in improved health. This might be done through cognitive restructuring or challenging people's beliefs about the hospitalization or procedures. This can be done through challenging and modeling more appropriate types of thinking. It could even be done through things like guided imagery or other relaxation techniques to help minimize the way that stress can promote state-specific cognition, where people get stressed and thus tend to think more pessimistically about the situation. This is often going to be helpful for all individuals, but might be especially important when individuals aren't able to control the situation or don't have a lot of choice about the situation, or maybe there aren't a lot of ways to problem solve. For example, if someone has to undergo surgery for cancer, but they're very distressed and nervous about it, but there's not any other treatment options available, this may be effective. On the other hand, behavioral control is when patients are taught techniques for dealing with their symptoms directly, and ideally to promote their own recovery. This is most effective when the patient can actually exert personal control. Certainly, this can include things like meditation or relaxation procedures, with the knowledge that reducing stress and reducing sympathetic nervous system activation can promote recovery. But it also focuses very much on lifestyle changes and problem solving for means to actually control or reduce symptoms or reduce the risk for relapse. A final area where health psychologists really have something unique to add to the treatment of patients is in the area of medical adherence. Most models of health behaviors tend to recognize that a patient must be motivated, must have accurate information, and must have the ability to follow through with a specific treatment regimen or a specific and individualized prescription for medical treatment. When we think about the importance of adherence with treatment advice, the outcomes that are associated with it really are important. Non-adherence with medical advice causes about 10 to 20% of patients to require additional medications that they wouldn't have needed if they had followed the medical advice originally. It also requires 5 to 10% of patients to require further office visits and days off from work that could have been avoided. It's difficult to come to a firm conclusion on number in terms of how high non-compliance is. Some research suggests that less than half of patients actually follow their treatment regimen to the letter, though about 3/4 of patients claim that they do so. Some other research suggests that the numbers for non-compliance might be even higher and might be as high as 75% who don't follow their medical advice exactly as recommended. The complications that come from non-adherence can be significant, and we know that non-compliance is very prevalent. Interestingly, the severity of disease or symptoms doesn't really seem to matter in terms of whether patients are following their medical advice or not. In terms of what does impact on whether patients are medically compliant or not, is how complex the treatment regimen is, as well as potentially how distressing or interfering the side effects of the treatment may be. We also know that depression lowers adherence to medical advice, and it's possible that anxiety and stress do as well. Certainly, as referenced before, being of lower income can lower adherence primarily because it's a barrier to access to or ability to follow through with medical advice. Again, the doctor-patient relationship is important, as provider displays of empathy and confidence can improve adherence on the part of the patient. Interestingly, the healthcare provider's own job satisfaction and the number of patients that the provider sees per week also impact upon patients' adherence. The more satisfied the provider is in their job, the higher the adherence of their patients, and the lower number of patients seen every week, the higher the patient adherence. I think it's important to recognize that the majority, 60 to 80% of treatment decisions, are based on information that arises from the medical consultation process. As managed care seeks to control costs by eliminating, quote, waste and, quote, unnecessary procedures, and by providing economically sound treatment guidelines to hospitals and physicians, there has also been a change in how healthcare works, where there's often overscheduling that's done to try to minimize lost productivity for no-shows or cancellations, and where doctors and other healthcare professionals are trying to get in and out as quickly as possible to keep productivity up. This is a very different model from the historical model where, for example, the doctor came to your home and was treated almost like a visitor while also a respected healthcare professional. Research suggests that patients often leave an appointment with their healthcare professional dissatisfied because they feel like they haven't received enough information. They feel like they haven't fully understood the medical advice they were given, and they perceive themselves as being unable to comply with the treatment instructions that they've been given. Thus, direct work by the psychologist with the medical providers to help them improve their ability to communicate their conclusions and medical recommendations, as well as to communicate their caring for the patient and their understanding of any dilemmas at hand, may go a long way in improving medical compliance in the provider's patients. In addition, psychotherapy with the patients of a medical provider with very bad bedside manner may help provide a substitute rapport that may help minimize the negative impact of the provider-patient interactions. Of course, a medical provider may need psychological intervention themselves. Health psychologists or other health professionals can also promote adherence by working directly with the patient. Psychoeducation can be provided to the patient about the importance of compliance with medical advice, and steps can be taken to help motivate the patient to want to be compliant. This could be done through a variety of strategies like motivational interviewing to help get people to a stage of change where they're more ready to adopt new behaviors. We can use reinforcement to get people to follow through with behavioral changes as well, such as using financial benefits like the reduction of health insurance costs, or rewards like a gym membership to help reinforce the changes that people make. We can also use setting events to help people make the conditions more conducive for their behavior changes to take place, like setting alarms to help them remember to take medication. We can also use modeling as a means to motivate people to change, as seeing other people successfully make recommended changes and benefit from doing so has a clear impact on motivating the individual at hand to do the same. Psychologists can also help patients problem solve. They can, on an individual level, look at the factors that are interfering with compliance and try to come up with actual strategies to solve those problems. They can help individuals learn coping strategies or more effectively elicit social support to try to promote compliance. For example, reaching out to other patients in the same unit or family members or friends to arrange for rides back and forth, and that sort to the treatment session, or for family members to help remind the patient to take the medication and that sort of thing. We can also address patient fear. We know that fear of medical procedures might be a big reason why patients are non-compliant, and we have definite strategies for reducing fear through exposure or systematic desensitization. Thus, health psychologists can offer a unique knowledge base and skill set to the healthcare organizations, medical providers, and or patients directly to improve compliance and treatment outcomes. The last thing I'm going to be sure to touch on in regards to seeking healthcare is the impact of our current managed healthcare system. The access to healthcare in the United States is much more restricted than it is in many other industrialized nations, many of which have nationalized health insurance or other types of universal healthcare coverage. Personally and professionally, this is an issue I feel very strongly about. I find it very distressing that many individuals in our society go without health coverage in the managed healthcare system or are undercovered. There are certainly programs that are in place that are meant to cover healthcare costs for individuals who are part of the most vulnerable population. For example, we have Medicaid, which is meant to cover certain medical expenses for individuals who are of low income. However, only about 43% of individuals who would be considered poor actually receive coverage through Medicaid because it's based on income and the presence of physical problems. We also know that there are many individuals who have historically had problems having access to care because health insurance is very expensive, especially for individuals who are not able to get it through their employment. Even when individuals are insured, there can be high barriers to getting health care. One group who has traditionally had a lot of trouble getting health care coverage are individuals who have pre-existing conditions. While such individuals are insured coverage as I write this lecture, the healthcare debate continues and such protections can easily end depending on the political climate. Health insurance is also very expensive, so many individuals are opting to be underinsured by choosing coverage with a catastrophic plan that is only really of any benefit if someone experiences a traumatic health occurrence. Those individuals who are underinsured might be engaging in more delay behaviors, or they might just be passing by preventative care or needed medical care because they just can't afford to pay the out-of-pocket costs. This results in a great deal of individuals who are suffering and who are impaired by health conditions simply because they cannot afford to receive quality health care. To me, this is a very, very distressing state of affairs because personally, my belief is that all individuals should have as a basic human right access to quality medical care regardless of their ability to pay. While many individuals think that this is the state of affairs in our country, it still is not, and any protections in place are subject to change at any time. Your discussion for this module asks you to deeply and thoughtfully consider healthcare coverage, and I hope you find it thought-provoking to do so. Please be in touch with any questions or concerns, and you'll hear from me again in the next module.